Welcome everybody who's joining us. For those that are just jumping on, we're having a few technical challenges here. Dr. Calantar and Dr. Kraus are working through those to join us quickly. Thank you for joining the session. I was going to go ahead and do a quick introduction of myself and to our two panelists that are here, and then hopefully our physicians can join us soon. So thank you. Looking forward to a great session here. My name is Michael Aragon. I'm the session moderator. I'm the Chief Medical Officer for Outset Medical. I've been a nephrologist for over 20 years. My main clinical interest is centered around everything we're talking about today, empowering patients. Most of my focus has been studying and developing technology that makes it easier for patients to take control of their care for their ESRD. Have the pleasure of introducing some excellent patient advocates and care partners here today. First, I'd like to introduce Jimmy and Dawn Bates, the stars of the movie earlier. Great patient and care partner team. Probably gathered if you watched the videos earlier, but Dawn has been Jimmy's care partner. They're performing short daily dialysis since 2009. And in addition to being a great team at home, they've been ambassadors of more frequent home hemodialysis, travel around the country, educating others on the benefits of this type of therapy. So great to have you both here live and not just in a recorded video. So thank you.
Thank you.
And our other panelists, I think everyone, if you've been joining us today or been active in the kidney community, you've probably met several times, but Nelcha Gedney is joining us as well. As you know, Nelcha is the executive director of HDU. She's been on dialysis now 9 years as a solo home hemodialyzer. In addition, Nelcha has been incredibly active and, in my humble opinion, very effective in policy and advocacy nationally and on Capitol Hill, really basing that on her strong belief that there's power in numbers and that's what it'll take to bring about change. So Nelcha, so wonderful to have you here as well. Thank you. Our two physicians, which will hopefully join shortly, will be joined by Dr. Michael Kraus. He is the Associate Chief Medical Officer for Fresenius Kidney Care. He's also held roles as a medical advisor and associate CMO for Next Stage Kidney Care and Next Stage Medical. Prior to joining the device industry, Dr. Kraus was in academic medicine for about 25 years at Indiana University, serving as a professor of clinical medicine, where he developed one of the largest home hemodialysis programs in the country. So we're very, very happy to have him join here, hopefully soon as we work through this. And finally, the other member of our panel that should be joining soon is Dr. Cam Calantar. Dr. Calantar is a practicing nephrologist, the chief of nephrology at the University of California. He's a member and co-chair of the Joint Steering Committee of World Kidney Day and the past president of the International Society of Renal Nutrition and Metabolism and the International Federation of Kidney Foundations. He serves currently as on the board of directors for the ESRD Network 18 and the National Forum of ESRD Networks. So that'll be our panel, and I think we're working through this. Mike seems like he's joined. Hopefully he can hear us. All right, thank you. Yes. You missed your introduction, but I think I did you good justice. So, and I think we're still waiting for Dr. Calantar to join. And most of our discussion here today is really going to be around frequency. The title of our session, The Right Choice for the Right Patient at the Right Time. So we'll talk a little bit about that. Nelcha, I think we can probably go ahead and get started if that's okay with you. And Dr. Calantar joins.
Cam will jump in when he gets on.
Yeah, I think probably the best place to start for everybody is really, we have quite a few people join the room. What are the options for how often a patient can perform treatments at home? Is there, data to support that one may be better than the other? And does that matter, specific to the patient, for example, if they still make urine or not? So Mike, maybe I'll start with you, and then I can have the patients share a little bit about what they're doing at home.
Oh, sure. Yeah, thanks, Mike. And thanks, everybody, for joining us. This is really exciting. The options are obviously everything, right? Everything's always an option. The question is, what is the best option? And how do we get there? So as we talk about frequency or options of therapy, you got to keep inside, where are you? Everybody's different. So not just is much different than Jimmy, and their prescriptions show that, right? In my mind, it is, as we think about the patient, what causes the patient to get sick, what causes, frankly, the patient to die, unfortunately, and how do we get them to transplantation? And volume is our number one poison, as you are well aware, and it's the heart that is our biggest problem. So when we look at the prescription and we think frequency, it is about maintaining a good volume, keeping sure that your intradialytic weight gains are low. And frequency and duration are really that drive that. So you have an excellent urine output like Nejda, and maybe your needs for removal of poisons aren't as great, less frequency might make sense. Unfortunately, most of our patients, particularly when they get to home hemodialysis, don't have a good urine output, don't have a good residual function. Frequency becomes much more important. And when we go, and we can talk about it, I'm sure, later as well, but as we talk about protecting the heart, 5 and 6 days is where all the evidence is generated. And that's why, I've always done 5 and 6 days a week therapy, but it takes empowering a patient. So the question is never, gee, Mike, would you like to dialyze 3, 4, 5 days a week? The answer is always 2, right? That's not a hard question. That's not the right answer. So for me to take you and help you as a patient to get to where you need to be, it's a discussion, it's education. I walk you through med school, if you will. So I'll leave it at that.
Yeah. No, great. Thank you. No, I appreciate that. And I'll turn a little bit to our patients now. You kind of alluded to Nelcha having residual function, doing a couple days a week. Maybe Nelcha, kind of give us a little bit of what your schedule is, and then we'll turn to Don and Jimmy and have them talk to us a little bit about what their schedule is. I think it's really important to have both of these views here.
So I've been on home dialysis for 9 years, started in center for just a brief time. And the first thing I actually noticed was the more dialysis I did, especially in center, the less I peed. So, and I didn't know, this was strictly intuitive, but if I did less and I peed more and I felt better. Years later, I found out that there's actually an incremental diagnosis that you can use to develop your treatment plan along those lines. But it's very, it takes a lot of effort. I do a lot of labs. I monitor it very closely. I do have to do 24-hour urine. But it also has given me that freedom by being able to keep my residual function for almost 9 years. Very few people have that luxury. And when you are like Jimmy, that have no function at all, you do 6 days a week because you feel better. I mean, tell them, Jimmy, take it away.
Yes, absolutely. When Jimmy first started doing home, it was 5 days a week, and then they upped him up to 6 days a week because he wasn't getting a good clearance. And then he got a transplant, crashed back in, and he started at 6 days a week. Mm-hmm. And after a period of time, and we had a conversation, and he just said, why am I not doing this every day? Your kidney works 24/7. And so he said to his doctor, hey, I know I can't get the 24, but can I at least get the 7? Yeah. And his doctor was very supportive. Mm-hmm. And so he does do it 7 days a week. But he also, as Dr. Kraus said, we have to look at the big picture, and we have to look at the cardiac, and because that's a huge thing for dialysis patients. And so through education and talking to wonderful people like Nelche and Dory, getting some knowledge and some information. And again, going back to the doctor, we always go to the doctor and talk to him, communicate with him. But it was like, all right, we're running our blood flow rate at 450. Can we slow that down? He's already got 2 stents. He's got a stent in his fistula. We want to preserve that. We're looking at the big picture, because, he may choose not to ever get another transplant. So let's help give him the best quality of life for as long as he possibly can.
So if I can, what Don and Nelja just said is exactly right. First of all, it takes collaboration, discussion with your physicians, understanding what your goals are, and making sure we talk about things, not how are you going to feel tomorrow, but how are you going to feel and what do you want to accomplish in 1, 3, 5, and 10 years, right? It's a long-term picture, and collaboration is important. And if I could, I'll do my best Cam Calantar impression because he's not here, but hopefully he'll join us. But Dr. Calantar is one of the leaders in incremental, particularly hemodialysis, but also involved in PD, as well as Dr. Davenport from overseas. The key is when they pick an incremental patient, and when we say incremental, that's a little hard, doing less than the usual amount of dialysis. We'll leave it at that. It's dependent on a few things. One is the volume has to be controlled. So the blood pressure has to be controlled. 2 is the phosphorus has to be controlled. And 3 is the potassium has to be controlled. So as you as a patient think about these things for your doctor, yes, you want to do 2. But in all honesty, that may not be the best therapy for you. And you've got to understand our goal, everybody on the panel, it's about optimal dialysis, which is symptom-free dialysis with volume control. And if Cam were here, that's what he'd say. Just say it a little bit more eloquently.
And one of the things that I learned early on from Cam is that there's very specific criteria. In other words, to
Right.
do incremental, you don't just randomly tell every patient, you're going to do 1 or 2 days a week. There's very specific criteria that Dr. Kraus just mentioned, things like your volume. You have to make sure that your output of residual or urine is greater than 500. And in my case, it's 1.5 to 2 liters a day, and has maintained that for 2 years. That has to be fairly productive. And the only way you can do that is through extensive laboratory work. So incremental does require more monitoring to know when it's time to move on. And I'm very cognizant of this fact. And any day now, I, could just shut down and need to move on. And I accept that. There's up to 10 or 12 different criteria. Those are some of the key ones. As you said, the phosphorus and potassium. You want to I monitor my heart annually since, I'm going on 10 years. So, I guess the main thing I want to emphasize is, one, you want to know that you have these options, especially starting out. That's where incremental, I think, is the most important for patients. When they're starting, it's gentler. It gives you a slower start. It gives you maybe the boost you need to accept home dialysis or hemodialysis or even dialysis in general as you're moving towards a full treatment schedule, whatever that is for you. And I hope I kind of did him justice along with Dr. Kraus.
No, and hopefully he'll join us shortly. But great discussion, and I think I think we can all agree there's not a one size fits all. It is going to be variable. Yes, everybody would like to do one treatment a week and be done, and that may be appropriate as in 2 day a week with you, Nelcha, but may not be appropriate for everybody. And I think the other thing we have to be honest about as a nephrology community, right? We have data at 6 days a week. We have data at 3 days a week. We don't have a ton of data every other day or 4 days a week. We know nocturnal, nightly. There's still a lot of room to learn, and I think as long as we all, we can all agree there are lifestyle things that we have to fit dialysis into. What are you living on dialysis for? And that's what we want to meet. And then there are obviously clinical things that we want to achieve because we want everybody to have a long life where they feel well. So it is blood pressure control, it is volume control, it's these laboratory values. And so it is not one size fits all. It's a lot of flexibility here, which kind of leads me, a great discussion to kind of lead me into kind of where I wanted to go next, because I assume a lot of the questions would be, great, Nelcha has a lot of urine output. Other patients don't. How do I know, right? And maybe Mike, this may be the first. I'll start with you here. Is how do you determine with the patient, what frequency is going to be right for them? Or is it lab values? Are you looking for certain things? Is it lifestyle choice? Like, how are you having that conversation to work with that patient to decide what you believe their frequency should be, or as a starting point? Obviously, things can change as you learn, but. Yeah,
so it's as I said, it's asking the patient first and listen. So and Dave Rush put it in there. It's about communication. Communication isn't me just talking to a patient. More importantly, it's me listening to the patient, asking you what your goals are, what you want to accomplish, and then it's me educating you so that you understand why I believe it's important to do more frequent dialysis. Because you talk to, as we've all seen, you go to in-center dialysis, patients feel terrible after dialysis. So if we've got people listening that do in-center dialysis and they hear Dr. Kraus going 5 or 6 days a week, they're going, I got sign language. No, they don't say that. They say, why would I do 5 or 6 days a week? I feel terrible 3 days a week. But it's backing up. It's not about dialysis. It's about optimal dialysis.
Yeah.
So it's not the fact that dialysis causes your symptoms. It's how you dialyze that causes your symptoms. Mm-hmm. So we have that discussion. And the rare patient that has a very good urine output, then, I can discuss a little bit about incremental. But when I discuss incremental, there's a few things you set up right front. One is it does entail, as I said, lots of labs. It does entail checking your 24-hour urine more frequently and you measuring it. And then it entails you understanding that at some point in time, it's in your best interest to increase frequency. So in my practice, a lot of the patients came to us from being on dialysis a long time without residual renal function. 5 or 6 days was easy. That was the discussion we always had. Nobody left my practice to go to someplace else because I said you have to do 5 or 6 days a week, right? They understood. So it's a matter of, again, meeting the patient where they're at, but making sure It's not just I, the patient, want. It's I, the patient, understand these are my goals and this is how I'm going to get there. I'm going to work and collaborate with my doctor.
Yeah, no,
Absolutely. And
Yeah.
and I think I was going to say I think it's so important. You know, you as a patient, especially a new patient, as a care partner. You know, Jimmy and I are a team. Everybody who knows us knows that we're a team. And when you come into this, you only know what you're told. All right. And so education is key. And like you said, and I appreciate so much, Dr. Kraus, saying that, you know, you have to meet that patient where they're at. Because for some people, you know, more frequent is like, oh my God, why would I want to do that? And we've heard that a number of times. I don't want to do 3 days. Why would I want to do 5? Why would I want? Because you're going to feel better. But there's no blueprint that says this is how it's going to be done. And that's how it is for everybody, because everybody's different. It's very individualized. You know, for Jimmy, travel is a huge deal for him. Okay. And yeah, travel can be moving your machine from one room to another. For us, traveling is going 22 states in 3 months, you know, and just loving life. So, you know, it's meeting that patient where they're at and helping them to accomplish their goals, because it really is about their quality of life.
And frequently, you know, you can try, you know, as a patient, you don't, we unfortunately think we walk into this one-way tunnel and we can't turn around or we can't go otherwise. You can try all sorts of things. And if you're on in-center dialysis and you're not feeling well and you have all the symptoms that we've talked about, talk to your doctor about doing dialysis more frequently for a couple of weeks. You can do it in-center. It's not about a device. Let's be honest. All our devices are just pumps. They pump blood one way, dialysate the other way. It's about the therapy. And frequency matters. Frequency delivered correctly matters. And you can try that as a patient. You don't have to wait to be trained on home to try it at home. Try it first. See if you like it. You get a test drive.
No, I think that's a great. And again, we've talked about, and we have patients, for those who are joining a little late, we have patients that are doing 2 days a week with a lot of residual kidney function, patients that are doing daily. I think it's important to recognize there's all sorts of combinations in between, right? And it's how you feel. Are you meeting your clinical goals? Are you keeping yourself in good volume status so you don't overload your body? So I think all of those things, it's important to know there's options, and try the different ones and see how you feel, and then find what works for you. Dr. Calantar has been able to join us, so glad to have you here. Thank you. Sorry for any technical challenges you may have had.
Well, thank you. I apologize that I missed the first 20 minutes, but I was just listening, and wow, what a great discussion. How much I just learned in the past several minutes about what was discussed. Thank you.
We tried to impersonate you really well.
We did. Yeah, I think, Dr. Calantar, now that you're here, I think it'd be great to, we talked a little bit about incremental dialysis. I would say we're all probably inadequate to having that, to being that person other than you, knowing as much work as you've done in this area, but would love to share with, we've got about 100 people on, love to share with them a little bit about incremental dialysis, how you're utilizing that. What are those things that you're checking to make sure that a patient may be appropriate for that? I think it'd be great to kind of share that modality, because I don't think it's something that's done very often throughout. Most of our patients have not had access to it.
Yeah, I think the key was what Don said here, that everybody's different. And we need to appreciate and acknowledge that. Now, you may say that, wow, this is very basic. We should know that. But this is 50 years of anniversary of the 1972 ESRD legislation, when the then President Richard Nixon signed in October 1972 the legislation. For the first time, this country covered that, and it was enacted, I think, in July of 1973. So next year will be the 50 years of dialysis operation. But then I was trained that dialysis is 3 times a week: Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Yet over 500,000 people on dialysis, they are asked to start thrice weekly hemodialysis or at home PD, being this way, with daily exchanges, several exchanges a day. So the question, I mean, we were just wondering, people are asking me, Dr. Calantar, so why do you think this was not discussed for 50 years? And I have no answer. I just can say that, look, people like Nilje came and asked me, doctor, I think I don't need as many dialysis treatments as they are telling me to do. And she makes a lot of sense. And I think many of us practice that. And Dawn's husband may need 7 days a week. And Dawn's brother or family member or neighbor may not even need twice a week, right? Mm-hmm. And based on the home dialysis, this machine, that machine. So I really, myself, I'm here to learn and to be educated by our patients, because we nephrologists, there are three of us, Dr. Kraus, Dr. Aragon, and myself, and then we are here to learn from our patients, because the patient is the head of the team, right? You guys tell us, Nilje, Dawn, you guys tell us what to do, what you feel you need, and then we are members of your team. We're working together to come up with something the best for you. The same way that people are not the same, people at different time, at different or different points in time are also different. So, for example, 10 years ago, I looked younger, but now I'm different. I can't run as much as I used to do. So then maybe initially when I started dialysis, I needed only 2-3 times, 3 exchanges at home with PD, or 1 exchange, or maybe 1 or 2 home dialysis treatments. And now 2 years later, 5 years later, I'm a different person, right? So my physiology has changed. I'm getting more gray hair. I'm a different person, right? So persons are different. People are different, are also across different points in time. They are also different. So we should always remember, I'm not the same person as I was 2 years ago. I tell my children, I can't lift this heavy thing for you guys. I may get suddenly some major issue, and you guys need to send me to ICU to do surgery. I need to be careful now, right? So the same way, I would like to ask our patients who say that less dialysis is okay. Now it may not be always okay, right? So I'm going to stop here. Thank you.
Yeah. And that's really good, Cam. We're all different, but physiology is still physiology. And when you think of quality of dialysis, and I just don't want the patients to come with the wrong impression. A good prescription will manage 80 to 90% of dialysis patients, because the physiology is actually quite similar, unfortunately. There are the 10 to 20% that need a little tweaking. You know, there's 500,000 people on dialysis. If everybody had a different prescription, it frankly wouldn't be a safe therapy. That's frankly how we started. And we know how we got to 3 days a week, right? Northwest Kidney, God bless them, because they are the greatest, started with 1 day a week dialysis. It didn't work. Patients got very, very ill. So they went to twice a week. It didn't work. Patients stayed ill. So they went to 3 times a week. And that's where it comes from. It doesn't come from anywhere else. That's just where it came from. And then adequacy, obviously, as we all know, that K2OB doctors talk about, that you don't care about. You do care, because going below a minimum threshold actually is bad dialysis. So when I go home, I want to deliver good dialysis with optimal treatments, the optimal dialysis at the end, where I really feel good.
Yeah. No, and I think that it's a great point, Mike. I think the other piece of that, right, is the clinical piece, and then you have to live on dialysis, right? You're doing this for a reason, and it's not necessarily always longevity. We've seen patient surveys. Mortality is not the highest ranking thing for patients. It's the quality of life, and patients have had, there's been surveys of patients that I'd be willing to give up a little bit of quantity in exchange for good quality. And so it is that balance, right? The frequency needs to fit the clinical goals, but needs to fit the quality of life that patient wants. And then there's everything between. And nobody feels good if they're in the hospital because they only do 1 day a week dialysis and it's not enough, right? So there is the balance of how do we meet that need for the patient to be able to do all the things they want to do in life and give them a very good quality clinically as well, so that they are not getting hospitalized, they're not short of breath, they're physically able to do the things that they want to do. So I think it's a great discussion. Cam, we tried to explain incremental dialysis, but I'd like to give you like 2 seconds to maybe kind of, when you see a patient that you think is an appropriate candidate, how are you having that discussion? And so there's a lot of patients here on that are listening in with late stage CKD that may be very interested in kind of how that works.
Well, I think Nilje had put together some slides about certain criteria, but we can essentially talk about them, Nilce, that in general, most people who start dialysis, most the persons, they still are making some urine, right? Otherwise, they wouldn't be without dialysis until yesterday. So that means they still go to bathroom 5 times, 10 times. They still make 1 to 2 liters of urine. And they were just here now to transition to dialysis. So we need to be cognizant that that's probably 80 to 90% of persons who start dialysis. But of course, they also have other problems. They have volume overload, they have hyperkalemia, and sometimes not infrequent, 40-50% of these dialysis initiations are done in the hospital where patients is at the sickest. And when we start, sometimes somebody on dialysis on an emergent basis, it could be daily in the hospital. Then patient goes home. There's some recovery. Patient starts having more urine. So we, based on the criteria that Nilce and I have worked on, and we are using it, the most important one is patient's urine volume. A more accurate surrogate of that would be measuring 24-hour urine and calculating patient's residual kidney function or urea clearance. So if urea clearance still above 3, like think of eGFR above 3 or 4. I mean, you may say, wow, that's still very low. But if your estimated GFR is, let's say, 5 plus, to be careful, then, and you're making urine, and you wake up, sometimes I ask my patient, do you still wake up at night to go to bathroom? Yes, doctor. I wake up twice. And I said, wow, that means you make more urine. So it's very interesting that it all started when we had a patient on dialysis twice weekly, and they told me that he interrupts the dialysis to go to bathroom, to urinate. And I said, wow, so what are we doing here? Are we really doing it correctly? It's not a bad thing, by the way, to make urine and to be on dialysis and to take advantage of both. So this is the most important essential for us. Among the 10 most important criteria is having adequate urine volume, making urine, and also calculating to see if that residual kidney function, which is now called residual kidney function because you have dialysis, is still having something around 5%. We say that if it goes below 3%, then it's a little bit too low to skip one dialysis session. So if for instance, the default home dialysis is 5 times a week, there are patients who may start and do quite well with 2 to 3 times a week at home using that certain machine, or with PD exchange. We have cases here who do 1 exchange a day, and people say, wow, how can 1 PD exchange be adequate? But they have done this. And then Nilce, for instance, is an example of, and then the question is, do I need to switch from twice weekly to thrice weekly, 4 times a week in 3 months to 6 months, in 1 year, 2 years? The answer is, I don't know. I have been all the time surprised. I've had patients and I said, look, let's run these patients in center Wednesday and Saturday. This is a shift we have created, Wednesday, Saturday, because of dialysis, some of our units are full. And then I said, it's very difficult for me to round on these patients because I usually go to the dialysis unit on Mondays or Wednesdays, Fridays, not Wednesdays. And then I said, it doesn't matter. In 6 months from now, he's going to be back to needs 3 times a week dialysis. One of my patients has been 3 years on Wednesdays and Saturdays and still makes so much urine, probably more than all of us together, and has done so well. So I still have the challenge of seeing rounding on him on a Wednesday month and a Saturday month. And then there have been patients I've predicted that they're going to do very well. Within 3 months, they're telling me, doctor, I don't make any urine at night anymore, and I feel congested. And I said, before you go to emergency room because of volume overload, let's switch you to more frequent. Just please come here for 1 additional dialysis, or at home, make it, instead of thrice make it 4 times, 5 times. So I wish I knew how to predict. And maybe we continue to come up with some prediction models. Again, that suggests different people, different requirements, different physiologic units. Not to mention that I come there, Dr. Kraus is correct. physiology is, the base is the same, but different people have different probably departures from the base.
And interestingly enough, I believe in history. I'm a big fan of history. And when you look at patients, frankly, you can do that. And the VA had a huge study on this. And actually in Fresenius, we've got one that we're trying to get published now. Patients decline for 2 years prior to dialysis at different rates. So your patient that's on twice a week dialysis for a long time probably declined at a very slow rate, because that's what they do. After they start dialysis, unless we do something, they continue to decline at that rate. It impacts survival, it impacts hospitalization, and frankly, if you're a believer in incremental, it would impact incremental. So, as I think about that frequency we talked about earlier, Mike, and what Cam just said, I look at the history. Mm-hmm. Where was the patient 2 years ago? What was the rate of decline? Because somebody that's going like this is not going to do well on incremental dialysis. Somebody that's the little that you've been following for 3, 4, 5 years, slow decline, you start them later. You can start them on incremental, and they'll preserve the residual renal function much longer. So history is important.
Excellent point, Dr. Kraus, because I actually had CKD for over 20 years, and it was an incredibly slow decline, partly because I was able to manage it. And so it's been the same thing since I've started dialysis. It's been a very slow decline. I do notice some changes, and I kind of have to point out that it's a double-edged sword, because when you have residual, your kidneys are functioning somewhat, but you don't always know how they're functioning. So 1 week they might pull phosphorus really good, and the next week they don't pull so well. So it really does require, as we said earlier, you have to monitor a lot more strongly, and often, and then analyze and even adjust those treatments based on what you see in your labs. So it's not necessarily, an easy solution, but it is one that can really help benefit. My quality of life is great. And just like Dawn, I travel all the time except for COVID. I fly all over the country, and I could not do that. I literally can get off a treatment and get on a plane. So these are the things when you talk about quality of life, and as you said, Dr. Aragon, we're not concerned about mortality. Truly, it's the time that we are here. It's got to be good times. And, if that quality of life deteriorates, then it's really time to reevaluate what we're doing, where we're at, and have that conversation with our clinicians. And, finally, and I'll shut up, one of the things I love to talk to when I'm talking to clinicians is to ask them, when was the last time you ever asked your patient, how do they feel? Because this is the key to understanding the treatment. How do you feel? More than any other test out there is, how do you feel? Because if you're getting a perfect KT over V, but you feel terrible, there's still something wrong. And I'm done. Sorry.
No,
and you made a very good point. It is about quality. But to be honest, quality dialysis leads to both quality of life and quantity of life. That's the long-term goal. That is what we truly want for all of you. That's why you look so good today. It is making sure that we give you what you need. So it's, again, symptom-free. I can't say that enough times. I probably haven't. But the symptom-free dialysis is absolutely critical to give you that quality. If I'm providing that, I'm also providing the best therapy for your heart, and probably the best therapy that's going to lead to your long-term survival. So nobody wants to die tomorrow if they feel great for 24 hours, right? I want to feel good for 5, 10 years, right? Yeah. But you're right. Nobody wants to suffer for 10 years either. So right. But I think they go hand in hand. Go ahead, Dawn.
Well, and I was just going to kind of piggyback off of what Nelce had said. It's, dialysis is forever changing, and our, Jimmy's needs 5 years ago are totally different from what they are today. Back when he was in center, he had 15 minutes to get home before he crashed, and he was done for the day. Now, doing more frequent and longer treatments, we slow down his blood flow rate. We slow down the UF rate, which means, he is dialyzing 3.5, 4 hours a day, every day. But he also has that freedom if he needs to take a day off, he can, but he has that energy that he can drive that RV all over the United States because I'm not doing it.
Right.
You know,
You answered my biggest question. Who drove? Now I know.
Yeah.
Okay. She can back it up.
That's great. So we've had a lot of questions, and I see Dr. Kraus, you've been kind of answering some of them here and there. I want to try to jump to those real quick, and then I was going to had one last question kind of for everybody. But let's see a few of the ones we've had here. One was around nocturnal dialysis. Why are nephrologists not or reluctant to speak to more patients about nocturnal? Maybe one of the physicians want to address that quickly. We've got like 4 or 5 of them, so if you want to kind of maybe touch on a high level, why that might not always be a common conversation.
It's a simple answer. It's because the doctor wants to sleep, right? Because the biggest thing is your assurance of safety from your point of view that it's a safe therapy, also from mine. Physicians aren't comfortable with nocturnal dialysis because we haven't done that. And then we're not comfortable with you doing it while I'm asleep and there's nobody else there except your partner who hopefully is sleeping, right? No good if Jimmy does nocturnal dialysis and Dawn's awake all night. So the biggest thing is getting comfortable with the safety. I am very comfortable with the safety. We have lots of devices that we add to improve the safety of the therapy. And it's a matter of education and discussion. But you as a patient, if you want nocturnal dialysis, which I think is an excellent form of therapy for so many reasons, discuss it with your physician. Advocate for yourself. I think that's what we're talking about. This is about collaboration.
No, and I think that's a great point. Nocturnal, that I 100% agree. Physicians don't talk about it because they're not necessarily as comfortable with it. It may also be for those who've not been offered a home modality. That may also be why your physician hasn't talked to you about home hemodialysis or PD. If they're not comfortable doing that therapy, their level of discomfort unfortunately affects your treatment. Exactly. So have those discussions. But I think that is often why physicians may hesitate to have certain therapies or offer certain things. It's their own discomfort, knowing that they may or may not be as confident in what they're doing. There was another question here. Does in-center hemodialysis offer more than 3-day-a-week therapy? I've been told that 3 days a week is the maximum. So I don't know if someone wants to.
No, actually, the answer is that most centers would accommodate more frequent dialysis. I think, as far as I know, almost every center, there are 8,000 dialysis centers in the United States currently. And most of them should be able to offer extra dialysis like 4 times a week or 5 times a week. If a patient requires that, would benefit from this. We have had pregnant patients every year. We have 1 or 2 pregnancy cases, and we do daily dialysis with the exception of Sunday, for instance. And patient comes here to us for a variety of reasons. Sometimes patients prefer to come to us so that he or she be watched closely, slow dialysis, lower rate, every day, 2 to 2.5 hours, very small amount of fluid removal. So if there are dialysis centers that are not accommodating more than thrice weekly, you can talk and ask them, is this because there is no chair available? There is not enough staff? For example, we talk about nocturnal dialysis. One of the reasons we lost our nocturnal shift in one of the units is because there was no staff anymore. After COVID, there is a major issue finding dialysis expertise, right? Mm-hmm. So, and therefore the best way is to shift these dialysis treatments to home. Home is the best place, and home is where 90% of PD is done overnight. If 90% of peritoneal dialysis can be done overnight, then so is also hemodialysis. So that's our trend, hopefully. With great colleagues and leaders, Dr. Aragon and Dr. Kraus, we continue to shift to that directions, and also being guided by patient leaders like Neelche and the family Bates.
Oh, great. Thank you, Dr. Calantar. There was a question too about peritoneal dialysis, which I thought was a great question. Was, I about to start PD at home, and does PD always have to be done every day? Can it be done less frequently? I think Mike kind of addressed it a little bit in the chat, but I wanted to kind of talk about that more broadly.
Yeah, actually, there are physicians, nephrologists who have those sort of experience and have done so. One of our nephrologists here sometimes starts PD also 3 times a week. Mm-hmm. And then we have another nephrologist who is remotely affiliated to us and does every day but 1 exchange a day. So that means the flexibility is there, but with flexibility comes also the challenge of dealing with different varieties. So that's a challenge for us nephrologists. That's one of the reasons that we would like, and we don't initially feel comfortable how to now deal with diversity, because there's always some level of challenge. But the answer is yes. However, I would really double check with your nephrologist, because there are good reasons. When a nephrologist say that I would like you to start every day, that's based on their experience. So I would team up with them and try to give the benefit of the doubt, not because just Dr. Calantar said in some chat in today that every other day is possible. Because I'm not your doctor. Your doctor is the one who is next door to you. So you should really have a great relationship with that doctor. And no matter what I say, the best team, the best way for your treatment is your local teaming up with your doctors and others.
I think that's a great point. And I was sorry. Go ahead, Mike.
A quick question. PD and our understanding of PD started with CAPD, which is 24/7 experience. We have since cut that down. We have 93% of people in America are on automated PD, which means a lot of them have dry days. It's not the same. It really is not the same. And when you then take that going to 3 days a week, it's not the same urea kinetics. It's not the same thought process. And I think sometimes we don't pay enough attention to that. Just like we talked about earlier, it's about salt and water control, potassium control, and phosphorus control. And so you've got to understand those things. And it sounds fun to do 3 days a week. I'm not sure it's better. And so I'm a big fan of 7 days a week. And in Asia, they start with 3 exchanges a day, which is really pretty easy. Morning, after work, and bedtime. Not hard to do.
Yeah, no, I think it's a great point. I think to me the discussion is the same as we were having with home hemodialysis, right? Depending on what your residual is, the therapy could potentially, move to different schedules. One thing to remember too with PD is it's a much slower process of toxin removal. So you have to give yourself time for that peritoneal dialysis fluid to pull those toxins out, which happens at a much slower process than hemodialysis. So there is a duration that you need to do that, and there is a frequency, but it could potentially be adjusted depending on who you are and where you are in terms of residual kidney function. Obviously, with zero urine output, I would be very apprehensive to put anyone on PD less than daily. And even then, that may be a very challenging therapy for them. But yeah, I think again, there's options here. I think the other big thing we've heard from everybody in the panel is communication. Talk to your physician, understand your therapy options. Why are they suggesting that you need 6 days a week? Or why do they think you might be able to do an incremental approach? You need to be educated. Your physician's gone to school for a lot of years. They should share that information with you. Ask the questions, and I think you'll find that communication be really great.
I was just going to reiterate that as much as it's great that, the doctors listen to us and have, diverse prescriptions, it is our responsibility as patients to communicate with your clinicians how the treatment makes you feel. And both of you should be working towards adjusting. I always tell people, when I am on treatment, it's like a Zen moment. I literally feel like I'm going into a coma. It is that gentle. It feels that good. I really look forward to it because it's like, oh my God, that feels good. And people, you laugh when I say that, but that's because I've worked hard with my clinic to get to that level. And, that blood flow, the dialysate flow, all of that plays into that. And so you need to be able to discuss all of these factors with your clinicians to arrive at that proper treatment, and then know that, like you said, it's going to change, over time, over years, sometimes even from treatment to treatment, it might change, a few minutes.
And even as you educate yourself now, Nelce, even as you educate yourself and you go to that doctor, there's more that comes out of that conversation.
Right.
Right.
We're all constantly learning together.
Yes.
Absolutely.
Yeah.
Every patient is different. So we got to learn each other. I'd like to kind of close. We've had a lot of conversation about frequency. And I think it might be really helpful for those that are listening. One, what might be some signs that you need to change frequency, right? Then maybe you need more, right? And then I think for the physicians, as you answer back, I'd love to hear, do you believe that too much dialysis is a possibility? And if so, what would be the signs potentially of that? And so I'd like to start with the patients, though. I know, Jimmy, you did less than 7 days a week at some point. What were you feeling that made you feel that something needed to change? This wasn't right frequency for me. And then Nelch, I know you did a little more frequent and backed off. So maybe, Jimmy, I'd love to start with you, and Don, maybe what you saw in Jimmy when he was doing a different frequency.
Go ahead.
At first I never thought about doing it more than just the 5 days or 6 days that I was prescribed. Mm-hmm. But I think I was feeling better, and with the 6 days, it's like I might as well do it that extra day too, and just do it every day because I felt better. Mm-hmm. So basically that's what it was. I was feeling good, and it's like, why not feel good every day?
Well,
no, that's great. So 100% how you felt.
Right.
Yeah.
And I think, in the beginning, he just did what he was told.
Yeah.
And then it was more of, I'm seeing him having more energy, and he's feeling better, and he can be more active and more involved. And God help us, the beginning of the pandemic, we were online schooling a kindergartner, a first grader, and oh dear Lord, help us. And we had a 2-year-old running around.
And doing my treatments every day.
Yes, absolutely.
So it was pretty crazy.
Yeah. But it is, it
I
truly
felt better,
is
so
about,
why not?
feeling better. Yeah. And he does. His quality of life is better.
Yeah.
He has more energy.
That's great.
And when I first started, I was doing 4 days, 4 hours, and I truly ascribed to that more is better because I was not that well educated at that point. And so I even tried doing 4, 5, 6 hour treatments. And I got to tell you, when I got off, I felt horrible, because that's me. And so I backed off, as Dr. Aragon so nicely put it. And as I backed off and I felt better and the treatment got better. And then, as I said, what I try to tell patients is you want to find that Zen zone. If you can find that, then it's great. Then your treatment's working, because everything, the planets are perfectly aligned. And, you feel great, and you get off and you don't even really know that you've had a dialysis treatment. That's what you want to look for. And it does take work. The patient has to work at it. The clinicians have to work at it. But that, I think, is where we want to be.
That's great. And now I will go from the clinician perspective. Maybe Mike, what are you seeing where you say, I think you need 6, not 5, or I think you need 7, not 6? And then, have you had the opposite where like, maybe we ought to decrease the amount of frequency you have? Any of those kind of conversations?
Yeah, so it's interesting. Usually I don't have to say, if somebody does 6 days, you should do 7, because they've come back to me and said that. So there are those patients that clearly feel worse, and usually they're with significant heart disease, significant morbidity. They say, I just don't feel good on that day off. Mm-hmm. Absolutely right. 7 days is easy. Too much dialysis is an interesting question, isn't it? Right? Because what's that mean? My kidneys work 24/7. I have a clearance of 110 cc's per minute. Dialysis isn't even touching that. Mm-hmm. Too much dialysis may be the way, again, you're doing it, right? I'm going too dry. Yep. Maybe my calcium is too low. I don't know what machine you use, but doctors tend to lower calcium, and you do conventional dialysis, you drop somebody's calcium in 2 hours, or drop their phosphorus in 2 hours significantly. These things cause you to feel bad. So it's how you do it. I think frequency is important because, again, it's like blowing up the balloon over and over and over again, which is what you're doing to your heart. You don't want to blow it up too far. That weight you come on in dialysis is absolutely critical. So yes, I understand that some people will do well on less frequency, but again, the majority of the patients, just from a physiology point of view, from the way our bodies work, frequency matters. So it's very rare that I went down below 2 days on, 1 day off, right? In 20 years, 2 patients I can think of.
No, that's fair. I think some of the potential too much, right? I know we've seen nocturnal daily in prior studies, mainly in Canada, where you're supplementing phosphorus.
Right. Yeah.
To me, if I'm having to give back phosphorus outside of your diet and you're already eating a full diet, I'm possibly doing too much. That I now
you're doing too much phosphorus movement. No question. It's how we dialyze it.
Absolutely.
That's conventional dialysis. 6 days a week is too much, I think.
No, if I could, Dr. Aragon, if I could add also, because I think Dr. Kraus' points is valid. I had quite a few cases, including actually last week, a patient who was saying that Dr. Calantar, this is too much for me. I can't do 4 times, because for him, I believe 4 times at home was the best. And then he felt post-dialysis fatigue. And then it turned out that the problem was low potassium at the end.
Yeah.
So it was on 1K. So we switched this to 2K dialysate, and he feels great. He feels greater. And now he wants even more frequent dialysis, to the credit of Dr. Kraus. And next week we may try 5 times at home to be consistent with what Dr. Kraus says. On the other hand, there are patients who feel miserable after dialysis when it's too much. I don't want to really compare dialysis to cancer chemotherapy, but if somebody doesn't need these toxic medications because his cancer is well controlled, there is no reason to give him more of these medications. So dialysis is a relatively safe procedure, yet it is a major procedure. Dialysis is like a surgery. So your blood goes out of your body for 2 to 4 hours and comes back. So if we can do this carefully and as needed, why not? And again, yet it's very important, safety, quality, and patient-centeredness. The patient is the ultimate. I mean, if the patient says, Dr. Calantar, I couldn't care less about these numbers you showed me every month I hand out in our VA, for example, in our 2 other units. So some of them are very smart. So what does it mean? Okay, I'm happy or I'm not happy. So how could these numbers help? Right? So maybe we should go back to Jimmy and Nelcha to see how we can learn from them. And please, patients, please continue to teach us. We nephrologists, I tell all young nephrologists, we have 6 of them at any given time and 17 colleagues, senior nephrologists. I always say that the best way to learn is to listen to patients and get their feedback. So please don't give up on teaching and educating us doctors.
Oh, that was great, Dr. Calantar. Thank you. Yeah, and I think I was just going to add real quick. Nelcha had mentioned she noticed her urine output was dropping when she did more frequent, and there is some science behind that, right? Urine output does seem to go down with thrice weekly dialysis. Now, there's a recent review for those that are interested in Hemodialysis International, looked at twice a week versus 3 times a week, maintained residual urine output longer. I'm not saying it's a better therapy. It was obviously a very specific population comparison.
It's valid.
And then vascular access, could potentially, if you're cannulating more often. So there are downsides. So to the point, it is a therapy. It's a treatment. And if you don't need it that often, or you don't need as many treatments, maybe that where I would say is defined as too much. But obviously, it is about the patient and communication, feeling well, and the clinical outcomes. We want everybody to feel well for as long as they possibly can, and I think that's our drivers. I think we're coming up towards the end of the session. I was going to give Dawn and Jimmy a chance to kind of any parting words, anything you'd like to share with everybody listening, and then Nelcha was going to kick it to you to let you close.
I would say number one, be your own advocate. Okay. Educate yourself and understand that, your doctor, your team, they're all educated. But just because, and no disrespect intended. Okay. But just because they have those letters behind their name does not mean that they know what's best for us, because we're the ones living it. He's the one that feels it. And we've done a great job advocating, but not on our own. We talk to other patients like Nelcha, like Dory, like other patients that are also walking this journey, and then questioning. And it's okay to question, because then we're educating not just ourselves, but also the doctor. So be your own advocate and get educated. This is your disease, and this disease is forever. So
I couldn't agree more. I started this, which is hard to believe, but when I crashed into dialysis, I knew zero about it. And I literally started putting one foot in front of the other, got through the training and went home and then started learning. And it was like a sponge. I soaked it up. And the more I learned, I read every scientific journal I could get my hands on, and what I tell patients, don't let those, scientific articles scare you. I always just read the conclusion and the abstract, and you've got your information. But the whole point is educate yourself, learn everything you can. And then you can help educate your clinicians, just as they've talked about.
Absolutely.
So
Absolutely. And for those, I think we've talked about in a few other sessions, there's resources all around the entire event today. And there's links to other sites that have more references and more materials. Please feel free to take advantage of that. Want to thank our two physicians for joining us. Dr. Kraus, thank you so much. I know you're very busy and really appreciate you joining. Dr. Calantar, so glad to have you. Thank you so much. 20 minutes late, but we were so glad to have you join. It was a great perspective. So thank you. And thank you to HDU for putting on this event. This has been fantastic. I love the energy. It's been a great day. So thank you. You guys have done a fantastic job.
Thank you.